So before I introduce the second speaker, our best friend and our colleague, Dr. Amar Lal, I would love really to thank Dr. Amar Lal being with us from Pakistan. Regardless of the situation that he is, I want to say that Dr. Amar Lal has lost his parents. God bless their soul. And on the behalf of the Emirates Oncology Nurses Society, that we're telling Dr. Amar Lal, we were extending our condolences and we're wishing him a safe trip back. If this would mean something, Dr. Amar Lal being with us, that means this is a great level of commitment to support cancer nurses, and this is a great level of professionality. And being here with us, it means a lot for all oncology nurses and all hematology nurses in the UAE and the Arab world also. So thank you for being here and thank you for being with us. Dr. Amar Lal, he's working in hematology at Tawam Hospital, and he has an extensive experience and training. He's qualified with a double FCRPS degree in a medical and oncology from the College of Physicians and Surgeons in Pakistan, CBSP, and he has also a double diploma from the Royal College of Physicians, MRCP, in medicine and oncology, and he's a qualified ISMO by examination board in oncology. So without any further delay, I would love to invite Dr. Amar Lal to the podium. Dr. Amar Lal, for your speech, please. Thank you.
Good evening, ladies and gentlemen. Thank you, Emirates Oncology Nursing Society annual meeting to invite me to talk on immunotherapy session in hematological malignancy. In next 15 minutes, I will take you some few steps how to remember immunotherapy journey and what to expect and multidisciplinary management of immune-related adverse effects and some frequently asked immune-related adverse effects, especially in COVID era. So just eye opener, what color is Rabin for non-Hodgkin lymphoma? The color is the lime. And then which guideline you use to treat hematology oncology? We use first 4, and out of this, NCCN is the topper. Now, what to remember? Common types of cancer immunotherapy are 5: vaccine, small molecule, then cytokines, but we'll focus on immune check inhibitor, which we call ICI, and out of this, we'll focus PD-L1. Why immunotherapy? Is again elimination, equilibration, and escape. Why? Because we have surveillance of immune system which scans our body from the cancerous cells. This equilibrium should be in dynamic equilibrium. If it is affected, then cancer cells, they actually invade the immune system and our immune system become weakened and the cancer cell enjoy the time. So, but we have if the immune system can be trained, again, refocused to recognize the attack cancer, it can be inhibited. Here is the picture which normally happens. You can say activated T cell, which cause proliferation, cytokines. This actually is anti-cancerous cells. But if you have chronic infection, persistent antigen stimulation, this system is exhausted and all proliferation of cytokines, it will go down and cancerous cell proliferate. But if you inhibit the PD-L1 and you use the blocker, this system is again activated. The SCOPE immune system is from 2011, in 1 decade, you have seen more than now 78 approval in 2011. Now we have used all the malignancies. So this is common scenario of 60-year lady who is the discussion about the immunotherapy. The first thing they will ask you about the potential side effect. This is the online answer. They have mentioned there's less side effect and less potential of discontinuation. Why? Immunotherapy, if you see in this cartoon, if you compare to the chemotherapy, it is double survival. And the adverse effect, you can see it in 8 papers of meta-analysis, it all favors the immunotherapy. Not only this, even fatal adverse effects is more in chemotherapy, less in immunotherapy. So immunotherapy is good. But before starting immunotherapy, you have anticipate 5 high 5. Again, you have to check patient has autoimmune risk. You have to check patient is any vaccination, and then reconciliation of the medication. Important thing is patient education and regular monitoring. How you do it? just set the evidence-based expectation, and benefit takes longer immunotherapy. And the important thing is the importance of monitoring and promote reporting of the symptoms. And more important thing is please carry on valid code at all the times to educate the adverse effect of immunotherapy. So here we'll go multidisciplinary management of immunotherapy. Yes, immune-related adverse events. You have seen here 5 is the purple, which is the common immunotherapy side effect, and 5 is the red color, which is the uncommon. So kinetics of onset and resolution is different. First thing is skin is first. You can see 35% people skins are affected, and then the GI and liver. So the kinetics is different. So you have to multidisciplinary approach. You are oncology nursing, and with the help of this 5 high common side effect and this 5 high of uncommon side effect, with this multidisciplinary, you manage the patient. How? You have to manage again 5 high. Number 1, patient education is essential. Number 2, stay alert, continuous monitoring, early identification, timely intervention, and evaluate the differential diagnosis. These are the 5 steps, very important. Then what are the gradings? Grade 1 is asymptomatic or mild symptom. You have to observe, but grade 2 have modern symptom. You have to intervene the immunotherapy. You have to start low dose of steroid, and grade 3 is medically significant. You have to stop immunotherapy. Patient may be hospitalized. Patient may need high dose of steroid, and is grade 4 a life-threatening urgent intervention and permanently discontinue therapy. Here, the key thing is please involve the specialist based on the which system is affected. The important thing is dose reduction of immunotherapy is not recommended at any time. So resources, NCCN CCO guideline, here is 5 steps. You can put your patients like which organ system is primarily affected. In this, I put endocrine, and then which endocrine adverse effect is patient experience, then enter the patient detail, and then how you plan the system. So here is the 5th is the recommendation you will find. So you can use this NCCN CCO, and they will give you the clear guideline based on the grading of the patient. And this patient, they supported endocrine consultation, hold immunotherapy, and start the treatment. First common 5 side effects. Dermatology, maculopapular rash is the number 1. Again, high-five. First presenting symptom, you have to see which rashes are there, papules, macules, and then second step is assessment. Do all the examination of the body, including mucosa, rashes, and also consult dermatology and consider biopsy. And third step is please rule out other causes. There may be cellulitis and contact dermatitis. And the 4th step is general supportive care, screen, sunglasses, oral antihistamine. And the 5th step is important thing is grading. If it is a mild, less than 10%, continue immunotherapy and local treatment. If 10 to 30%, continue immunotherapy, use oral steroid. But if it is more than 30%, you have to hold immunotherapy. So in this, you have seen re-challenge any grade rash, grade 1, when it's grade 1. So maculopapular is not bad, but the bad thing is bullous dermatitis. When you have bulla, blister, slough, this is important, and you have to consult immediately the dermatology. Even this here, you can see in mild grade, you have to hold immunotherapy, and in severe and life-threatening, here is mentioned, don't re-challenge even up to grade 3 and 4. So you have to take care which type of dermatitis is. So number 2 is the colon. In this patient, immune-related diarrhea happens, colitis. You started steroid, but it didn't work, and diarrhea has increased. So what you will do? The answer is you have to hold immunotherapy, and you have to aid in infliximab. So how it works? It works. Suppose in this case you have seen the colitis has happened of immunotherapy. So this is the guideline. Presenting symptom, it can present with the frequent stools and with abdomen pain, and you have to assess by the stool examination and imaging, like in this case we did it, and then rule out the other causes as well, infective and other processes. Then finally you have to make which grade it is. If it is mild, less than 4 stool, then consider holding immunotherapy and start some local treatment. And then you have to start, if it's grade 2, the prednisolone, and grade, or if it is refractory to steroid, then you have to infliximab. This is how you can re-challenge up to grade 1 to 2, but don't re-challenge beyond the grade 2 in GI. Then again, like suppose this is case 3, patient with immunotherapy, they develop grade 2 transaminitis. You start steroid, but it developed grade 3 transaminitis. Then what you will do? Here we will see in the guideline, the presenting symptom, usually in the hepatitis, usually asymptomatic and liver enzyme you find, but sometimes they present with abdomen pain, emesis and nausea and vomiting. You have to consult gastroenterology and you have to check all the panel from LFT to coagulation and imaging and rule out the causes, especially the patient has alcoholic or viral infection, because there is chances of reactivation of the viral, and then you have to make the grading accordingly. The number of the enzyme up to 3 times higher, we call it a mild grade, but you have seen in the beginning, you have to hold immunotherapy, and in second step is you have to state steroid, and if it's not work, you have to add mycophenolate, and here is what infliximab is contraindicated during hepatitis. Don't re-challenge up to 4, but up to grade 1 to 3, you can re-challenge immunotherapy. Now, endocrine, most common is the thyroid, usually present with the first with the thyrotoxicosis. You will, if thyrotoxicosis is not noticed, then patients' thyroid become not work, and then eventually it become hypothyroidism. Initially asymptomatic hypothyroidism, you can pick by TSH level, or clinically hypothyroidism, you can pick by the TSH and T3/4, and also in the symptom as well. The important thing is here is you can re-challenge. You after giving the thyroxine, no problem, you can re-challenge any grade. But the important thing is don't re-challenge if your pituitary inflamed. Now, what is the pituitary inflamed? Hypophysitis and adrenal. These are the very life-threatening condition in the endocrine. You have to first localize where is the problem. If it is a problem in the adrenal, by checking the cortisol and ACTH, or problem is in the pituitary by checking the hormone levels and the MRI. The important thing is the notice, don't re-challenge symptomatic pituitary inflammation. If the hormones other than the hypophysitis, you can just re-challenge after giving the replacement of hormone. Now, fifth, a patient with immunotherapy whose basic saturation is 90%, now it falls to 80%. CT scan show grade 2 pneumonitis. Now, what you will do in COVID era, you have to very careful, perform rapid COVID test, and you have to start steroid and antibiotic and conduct ECG to rule out a myocarditis. So here is the patient in pneumonitis, which started on steroid, which was typically immune-related, and it resolved accordingly. Now, guideline. How they present respiratory symptoms from dry cough, wheezes. An important thing is you have to check the oxygen saturation and HRCT, because chest X-ray will not pick it, the inflammation and pulmonary function test. And third step will rule out the other causes, infective and pulmonary embolism. And again, grading 1 to grade 4. Important thing is you have to hold immunotherapy all the way. Initially, steroid will work. Later, maybe you have to add something other immunotherapy. And the important thing is you have to re-challenge up to grade 2 and 3 and 4 out of the question to re-challenge. Now, less common immune-related adverse effect, the patient had the shortness of breath, and you have find in the ECG new bifascicular heart block. So what you will do, discontinue immunotherapy forever. Why? You can see the guideline here, how they present with the malaise, fatigue, and all these things. You have to check the biochemical, TROP-T and CK, BNP, ESR, CRP, and ECG and echo, and rule out the other causes. And the guideline is here, re-challenge up to grade 1, but never re-challenge up to 2 to 4 in the cardiac toxicity. Neurological toxicity is peripheral neuropathy and GB syndrome. Again, peripheral neuropathy is no problem. You can re-challenge up to 1 to 2, but don't re-challenge in the GBS and transverse mellitus in the neuropathy. Now, other is optic neuritis. Here is, you can see from inflammation of optic nerve, scalar enhancement, conjunctive edema. So you have to consult the ophthalmology. Step 2, they have to check, they have to find, is there any infective process, or really it's secondary to immunotherapy, and you have to treat, consider resumption, the treatment, any grade once it resolved to less than grade 1. Musculoskeletal, it can be in the bones, arthritis from mild to moderate severe, it can be to the muscle. Depending on this, anyway, you have to hold the immunotherapy, and in moderate, you have to oral steroid. If it worsens, you can use the DMRD, and you have to consult the dermatology as well. So pancreatic elevated enzymes, usually they present with elevated enzyme and sometimes in clinical as well. And you have to, again, re-challenge up to the grade 2-1, but don't re-challenge when grade 3 and 4. Renal toxicity is same. You have to check the patient with the nausea and azotemia, again, creatinine, electrolytes. If you have to hold immunotherapy all the way, important thing is don't re-challenge when it's grade 3 and 4. So this is how common questions are immune-related adverse effect associated with outcome. Here is the key. You can see the patient with the adverse effect, interestingly, they have the higher survival, and even PF is higher if the patient have the side effect. Very interesting. And then second is considered for the guideline for steroid therapy. This actually we extrapolate from immunology and rheumatology people. Taper at least 30 days. At least you give 30 days, then long-term therapy should be given. It's not like hematology, we give 6 to 4 weeks. Here it takes months and months, then you have to taper off because of the chances of failure of the disease. Now, the hot topic is the COVID cancer. You can see in first now a delicate balancing has occurred. Now, COVID has, high weightage nowadays. So you have to be very careful in this because of the hyperinflammation. And when there is high virus effect, the question is what the research says, whether immunotherapy associated with the more COVID outcome. There is again two data. One, they indicate they associate the more severe COVID. Others say there is no association between COVID and immunotherapy. So other question is, which of the following is reported patient with the Pfizer vaccine of the COVID-19? So they have mentioned in 75% that don't associate with the changes in timing and incidence. So it means it is safe. Where here I show, this is the difference of the adverse effect. This is the red is the control, and this blue is with the immunotherapy patient. You can see there are slightly difference of the side effects. Otherwise, it is acceptable. What the NCCN guideline recommend for COVID-19 vaccine for the immunotherapy? What they say the committee support the use of any of available EUA approves the vaccine in patients who are eligible. Again, three other guidelines, what they say, AACR, they say the patients receiving ICI should be considered for priority of COVID-19 vaccination. ESCO also said that patients may be taking COVID vaccination, and SITC guideline, they say should receive FDA-approved authorized COVID vaccination. So take-home message for vaccination is benefit of COVID vaccination outweigh the risks. So it's important they can take vaccination. So in last 15 minutes, you have seen, I have gone through eye-opener and what to remember in immune check inhibitor ICI journey and what to expect when to start therapy. We have gone through the multidisciplinary management to focus on the common side effect and less common side effect. And we focus on some very important questions, especially hot off the press of the COVID-19 vaccination. And this is my final take-home message. Thank you very much. If any query, I will be happy to answer the question. Thank you very much. Please.
Thank you, Dr. Lal, for the wonderful presentation and the great speech. I mean, as usual, this is a university level presentation. I like that. I have two questions for you, Dr. Lal, only. The first question is how we can choose between immunotherapy for Hodgkin lymphomas, as example. And the second question, why should they use Opdivo over Keytruda or the versa-versa? This is one question. And the second one, we've seen a durable, excellent response for Hodgkin lymphoma patient with Opdivo and other immunotherapies. Maybe some patients, they maintain excellent disease-free survival for almost 3 or 4 years. How long we can continue giving immunotherapy for these patients? Thank you.
Yeah. Thank you,
Dr. Khalid. First of all, thank you very much for your kind words and condolence for my parents. I am really grateful to you. So it was my committed to be here. So I came in between my, reciting all the other things which is going on in my home. Regarding, both questions are actually very practical questions. Whoever asked is really very practical question. He was asking actually, the thing is when to give immunotherapy in Hodgkin lymphoma and duration of therapy for Hodgkin lymphoma. The thing is, we usually give, any patient, Hodgkin lymphoma is potentially curable disease. Most of the patients, 70-80%, they are cured. Only 20 to 30% is the problem with the Hodgkin lymphoma. When it relapses, the standard treatment is high-dose chemotherapy followed by autologous transplant. Even in our setting in Tamam, very well, we don't have autologous. So people, 50%, they don't go for immune transplant, and they are doing great also. So this is how. Now, when the disease relapse after, salvage chemotherapy or plus minus autologous transplant, then the turn will come of immunotherapy actually. That time we give immunotherapy, we offer immunotherapy, and both immunotherapies are, FDA approved, and both are in NCCN guideline. You can choose any one, whatever is convenient, Pembro or Nivolumab, both are fine. So this is how. So we have huge experience of Hodgkin lymphoma, about 10 to 12 patients we have around currently who are on actually immunotherapy. The thing is, we are facing same thing, when to discontinue. The thing is, our patients, they're doing great. Some patients, they are even more than now 2.5 years or 3 years, almost one patient reached. A few patients are about 1 year plus. So usually we don't off therapy because the problem is this is continuous supportive care to activate the own immune system, which is the logic which I presented in first slide. What is the mechanism? The mechanism is the person's own immune system is disturbed, so we are pushing up the immune system. It is like, you can say, it's a pillar, it's bridging, you can say. If you take out the bridge again, the support to bridge will fall down. This is the problem. This is the continuous therapy. So that's how, we cannot pull out otherwise bridge will fall down. Very simple, I'm telling you. So that's why we will continue. But, even here, no dose adjustment. Even, in chemotherapy, we do it like, reducing dose, frequency, increase frequency. But here, these formula will not work. Neither frequency nor dose up and down will not work. Either you give or don't give. So some people, again, insurance issue, cost issue, it's very expensive therapy. We have tried honestly, right? So eventually it come back. Then, we start again another protocol like gemcitabine and bendamustine-based chemotherapy that work actually very nicely actually. So in short, we can off it after 2.5 years if there is issue. Otherwise, don't off. So thank you very much.
Thank you. Excellent, Dr. Lal. Thank you for the answer, and thank you for the wonderful presentation.